Welcome everyone to week 6 of DDU practice cases, and we might just get straight into it. I think I've already introduced the week to all of you that are on, so there's a few general ultrasound things this week. I think you might have missed that. Who wants to go first with some lung ultrasound practice? Each slide is a different patient. Rishi, you're at the top.
Yep.
Okay.
So we're looking at a lung ultrasound at the right apex, which shows prominent multiple almost confluent B lines emanating from the pleura, which is suggestive of interstitial edema.
What could be the cause of that, Rishi?
So the cause could be either infective or non-infective. Infective causes could be pneumonia from multiple microbial infective causes. Non-infective causes could be cardiogenic pulmonary edema, could be inflammatory pneumonitis, or any hemorrhage. So this is a lung ultrasound done at the right lung diaphragm edge, which shows a minimal pleural effusion along with a collapsed lung, which is this sign is also called a SAIL sign, I think.
Is there any other sign that you can see on this loop?
So in addition to that, there appears to be some echogenic matter, which is at the hepatorenal junction, which is concerning for some intraperitoneal hemorrhage. The lung midzone, a lung ultrasound in the lung midzone, consisting of dense consolidation in the right lung, along with dense irregular consolidation with dynamic air bronchograms. So this is highly suggestive of the pneumonic consolidation process which is going on. So again, this is a lung ultrasound which is done at the left base in the lateral side, which is showing some fluid with some heterogeneous opacifications, along with a collapsed lung. And this is concerning for a complex or a exudative pleural effusion, possibly an empyema.
Rob, can I get you to take this next one?
Sure.
Can you explain what's happening here?
So this is a spectral Doppler, pulse wave Doppler, and it looks like the gate is at the LVOT. There's significant spectral broadening happening here, and aliasing, I should say, as well. So the trace is filled in, which is the spectral broadening, and then is going over the baseline. So presumably the velocity is too high to be able to be measured accurately. This is
here, Rob?
This is again pulsed wave Doppler, but more toward the mid cavity. So there are two traces here. Again, there is some aliasing occurring, which is happening, which is probably capturing some inflow into the left ventricle, but then there is the trace, which is heading towards the LVOT. It's showing a sort of mid-systolic notch that can happen with mid-cavity obstruction.
What's the little red gate down at the bottom in the far field?
This can happen when you if you're using what's it called, power Doppler, to be able to measure higher velocities, and so the ultrasound is choosing to ignore velocities at a certain depth, so that it can measure velocities at that further depth.
Can you explain to me what aliasing is from a physics perspective?
Yeah, so aliasing is when the Doppler shift is greater than half the pulse repetition frequency. So when the velocity goes beyond, so the maximum velocity that can be read is half the pulse repetition frequency, and so if it goes above that, it'll travel across to the opposite side.
What type of Doppler do we see aliasing with?
Both color and pulsed wave Doppler, color being a mode of pulsed wave Doppler.
And how could you correct this image? What kind of strategies can you do to eliminate or minimize aliasing?
So you can reduce the depth, that'll increase your maximum pulse repetition frequency. You can also adjust the baseline and velocity scale so that you optimize your image. And in this image alone, depending on what you wanted to look at, you would reduce, or you would increase your sweep speed so that you have less cardiac cycles per image.
Does that help with aliasing though, reducing the sweep speed?
No, sorry. Not to misunderstand. That won't help with aliasing. It'll just help optimize your picture. Not suggesting that.
Cool. All right, we'll end that sort of point and shoot one. Nice one. I think you said everything there, Rishi. Did anyone have anything else to add? No, there's lots of, as you say, almost confluent B lines. You can't really see the pleural line to see whether it's thin or thickened, because that can help you as well, can't it? Differentiate between sort of cardiogenic and non-cardiogenic interstitial processes. Yeah, nice pleural effusion, a little bit of collapsed lung with the lung curtain sign. And also I was just wanting that spine sign at the bottom there, Rishi.
Oh yeah, spine.
I think just I couldn't see it. I can't appreciate any brief fluid there, so just be really careful, because I have a tendency to do that as well. When someone prompts you, you start that, I think that's a red flag in my mind for me not to say anything silly and overcall things, because I used to do that too with Viva practice, when someone would say anything else and then I just make stuff up that wasn't even there. It's like, it's such a weird thing. Which is, yeah, just be mindful of that. So and they will prompt you, depending on your examiner as well. Some prompt more than others, I think, and yeah, just be mindful of that. Yeah, nice one. How cool is that? Those dynamic air bronchograms, hepatization of the lung with all of these, yeah, dynamic and static air bronchograms. So probably a bit of consolidation, maybe a bit of collapse as well. And nice, massive pleural effusion, collapsed lung, and all this sort of particulate matter in it. You can't, which could be exudative, absolutely. You can't see any septations, which is, I should have included some actually of an empyema. I'll put them in maybe for next time. Nice one, Rob. I think they do like asking about aliasing and and what the clinical relevance of that is. So range ambiguity, sort of inaccurate imaging, and what you would do at the bedside to alter that if you do see it. So switching to high pulse repetition frequency modes, reducing the frequency of your transducer potentially. Shifting the baseline doesn't fix aliasing, but it's more sort of cosmetic. It does make it better, like make the image look better. And as you say, reduce the scale. Nice. What was I going to say? Yeah, this obviously you can see a bit of so you get range ambiguity when you get these ghosting gates pop up. So you don't know where it's sampling from. We can see some mid-cavity obstruction, as you said, and then you've got the mitral inflow coming, sort of that alias mitral inflow coming through, because it's called wraparound, isn't it? Because of that range ambiguity, it's not sure where it's coming from. And you're absolutely right. It's the Nyquist limit is half the pulse repetition frequency, and that's because if you've got a sine wave, it needs to be sampled. That sound wave needs to be sampled at least twice, so that the machine knows what direction it's coming from. So just make sure that you're able to just look at some Dopplers of different aliasing phenomena, because it's common that comes up. For example, a mitral inflow trace with a wraparound in systole, that's going to be an MR alias trace next to it. And yeah, be able to explain what you would do to get rid of it. Obviously, continuous wave Doppler, you don't have aliasing phenomena. Yeah, and just be able to explain that in quick, simple language, I think. But it's really all about the clinical relevance and what you would do at the bedside to change it. Cool. All right. Who's AD? Andy. Hi, Andy. I've not met you, I don't think. Are you new to joining? Sorry, I haven't.
Hi Emma, yeah, I'm new. I've attended a few previously, but I'm relatively new. I've kind of started the DDU about 9 months ago, so I'm fairly early on in my scanning career.
Oh, cool. Okay. Just for this week and practice and stuff, I might stick to the 3. Is there anyone else online? Sorry, guys, that's sitting soon. I've got Rishi, Robin, here one. But if there's anyone else that wants to practice a case, just speak up or put yourself on, turn your camera on maybe. Otherwise we'll keep going. Here one, I might ask you to do this one if that's all right.
Yeah. So 54-year-old woman, elective admission for angiogram after recent non-STEMI for AKI. Angio delayed to allow kidneys to recover. It's a difficult procedure in small RCA dissection. ICU overnight, CCU, no CCU beds. Tow next day for follow-up.
Just a routine tour.
Yeah,
Next
yeah.
day. I don't want to give the game away.
Oh, okay. So mid-esophageal 5-chamber view. Look, LV appears hypodynamic. I mean, I can't appreciate any wall motion abnormalities here. The LA looks significantly enlarged. Hypodynamic LV, someone had a recent non-STEMI. I'm worried about MR, but I can't see any obvious 2D defect. Yeah. Okay. So there is aortic like a central aortic regurgitation here. Look, I mean, just looking at this color scale alone, look, and with it looks significant, but I couldn't really comment on the severity. Look, again, LV is not dilated; it's hypodynamic. So I'm worried that this is acute. So I'm just trying to put this together with the clinical history. So I'd like to look at some other Doppler parameters, but also 2D appearance of the aortic valve leaflets to ascertain the etiology. Yeah. Okay. So look, to 2D appearance, it's very abnormal. Look, I mean, there is, especially in the non or the left coronary cusp. I mean, the right coronary cuff at the bottom of the image appears normal, but like there's usually it could either be non or left coronary cusp on the top of the screen. It almost looks like there's a discontinuity, perhaps a perforation of the aortic valve cusp causing the regurgitation. I'd also want to look at unfast view of the aortic valve actually. So in the collar floor, I wonder if there was some splay artifact suggesting like it's a significant regurg. Gosh, okay. So this is short axis view, so it's unfast view of the aortic valve as well as the RV inflow outflow tract. What I'm most worried about is this area of echolucency adjacent to the sort of the right and a non-coronary cusp. Look, again, I'm worried about a nitrogenic injury here to the aortic root, causing perhaps aneurysm or rupture or aneurysm into the sinus of Valsalva, but the color Doppler wasn't very significant. Oh, there it is. Okay. Right. Okay. Now I can see clearly a 2D evidence of dissection flap in the ascending aorta, which is probably a complication of the coronary angiogram and resultant AR. Yeah, again, this echolucence is much more prominent, again, consistent with dissection. And
What other views do you want now, Hewan?
yeah, so I'd like to look at the ascending aorta, or examine the aorta more closely. So, sorry, let me just recap. We looked at the long axis view of the aortic valve. I'd like to look at the so arch and the descending aorta in both short and long axis. Yeah, so again, this is all consistent with aortic dissection here. The clear 2D dissection flap.
Good, Hewan. Can you summarize the case for me and let me know what you would like to do next for this patient?
Gosh, yeah. I mean, these echo images are consistent with type A aortic dissection, and given the clinical history, I'm concerned that this is, it's an acute iatrogenic aortic dissection following an angiogram. Look, I'd like to do a CT aortogram to look at incomplete extent of the aortic injury, and the patient needs an urgent cardiothoracic consult because this needs an urgent surgical repair.
Very nice. Tell me how you would differentiate between a true and a false lumen with echo.
Yeah, so using 2D and Doppler features. So 2D, false lumen tends to be larger, and some other simple, and using Doppler on color flow. So true lumen has flow predominantly during systole, whereas false lumen, that's not the case, and the flow can be irregular. And the other 2D feature is true lumen should have systolic expansion, as you would expect, whereas with false lumen, you would have diastolic expansion. Yeah.
Anything else?
No, I can't recall.
Tell me, what do you think the mechanism of the AR is then in this case?
Yeah. So look, I might just gather my thoughts a bit. I think in the context of dissection, look, given the leaflet of the non-coronary or the left coronary cusp look abnormal on 2D, look, I think it's due to excessive leaflet motion in the context of dissection. Like the root doesn't look dilated to me, so just on 2D, just on subjective assessments, I don't think that's the case. Is I wonder if sort of extension of the dissection flap causing excessive leaflet movement.
Nice, Hewan. Good. I think that would have been like a really good Viva. I think you did really well. Yeah, iatrogenic aortic dissection following an angiogram. Probably what's happened is, I might just go back for everyone. Mid-esophageal 5-chamber, as you said, hyperdynamic function. The RV looks okay as well, right? She had an inferior RCA stent, I think. The mechanism, probably when you get here, that looks like a really nasty, as you say, sort of colour splay. Can't really see a Pisa, but it looks highly eccentric. And as you say, with that lack of LV remodeling in this history, you very much worry about an acute cause of aortic regurgitation. And the two main things are going to be dissection and IE, right? And there's different mechanisms for aortic regurg and dissection. I think we've been over this in the aortic regurg talk. You can either get some of the dissection flap sort of hanging down into your LVOT, leading to a coaptation defect. You sort of tether because you get aortic root dilatation, so you get a coaptation, defect with sort of tenting of the leaflets, or you can flail your cusp as well, so you can get a flail cusp into the root. So there's a few different causes, and it's a little bit tricky because we haven't got full images, but I think it's that right coronary cusp. It's got a bit of dissection material attached to it, and can you see it there landing into the LVOT? And I think that's going through with the right coronary cusp and just leading to a coaptation defect. I haven't shown you enough detail to say whether it's a moderate or severe AR, but it doesn't really matter because of the mechanism. It's going to be mod to severe, and looking at the colour, it looks pretty nasty and probably heading towards severe. But what would you want to look at to try and what would be the one thing that you would probably want to look at to see if you could quantify severity a bit more? When it's so eccentric. Yeah, when it's so eccentric like this, and you can't usually use it.
I mean, evidence of raised LV and diastolic pressure.
No, in terms of severity of AR, sorry.
Just AR. Eccentric jet, some direction like this. I mean, density is not going to be useful. I mean, pressure half time is probably still going to be useful, actually. That's what I would use.
Yeah, so the pressure half time is going to be obviously impacted by
so the flow reversal in the descending aorta.
Nice. Yeah, I think so. I think that, in acute severe AR, that's probably when it's very eccentric, I must say, is probably one of the most helpful things. If you see any sort of diastolic flow reversal. The problem with acute severe AR is that you don't necessarily. Sorry. One's gone, but for everyone else, with acute severe AR, of course, you don't always get that hollow diastolic flow reversal because of the rapid equalization of pressures, basically. So you can get sort of just a steep but non-hollow diastolic flow reversal in acute severe AR. Here is where the money shots are, I think, where you start seeing the mechanism of that nasty looking AR jet with this big, awful dissection flap here. I could have asked sort of how you would, is that an artifact, how you would interrogate artifact versus true pathology and the things that you would do, you know, to simple things, right? So zooming in, orthogonal views every time, right? So you're going to biplane all of that, and then you're going to look in different angles. You're going to do everything to increase your pulse repetition frequency, basically. So reduce the depth down, increase your frames per second, narrow the sector width, maybe M mode to appreciate its temporal resolution and its independent motion to other structures, putting color across it. Can you see the true and false lumen, seeing the entry point of that? Yeah, so often sometimes in sort of a more chronic dissection, you might see thrombus as well in the false lumen. This is, short axis of the aortic valve, slightly off axis, but showing that awful dissection flap, probably with a bit of thrombus in the lining of that, like layered thrombus happening there in that intimal tear that you can see. Again, pulling up and going round to, so this has gone from the RV inflow view because you're now at 70 and you've pulled up a little bit to be in that proximal ascending aorta, and you can see that awful you know, dissection flap extending all the way up, and then the descending aorta showing the dissection flap and the true and false lumen. The thing I was going to say is, what else would you look for here, one, in this circumstance? So consequences of aortic dissection. We've already got one of them in aortic regurgitation. What other things would you want to have a good look for?
Any pericardial effusion.
Nice.
There wasn't any evidence of that.
Yeah.
You could have dissection could extend into coronary artery territories. You could have regional wall motion abnormalities. Yeah.
Yeah, nice. And I guess hemothorax as well. But yeah, pericardial effusion and regional wall changes. And I didn't show you the transgastric views and stuff to see whether there were any obvious regional walls, but those are things that you would ask for as well. All right, who wants to practice? Should we go back to Rishi? No, maybe go Rob, because Rishi just did some general stuff. Rob, are you okay to take this one?
Sure.
These are all still images. I haven't got the loops.
Yes. Yeah, no problem. So this is a 52-year-old female with septic shock, admitted overnight from ED, 24 mils an hour of noradrenaline, clear cholecystitis, awaiting abdominal ultrasound. So this to me looks like it's an ultrasound of the liver and gallbladder in long axis. The concerning features are that the gallbladder wall, although not measured, appears thickened. And then there are some dependent query gallstones, which are evidenced by the sort of hyper-echoic nature of them with the acoustic shadowing deep to them. So I'd be concerned with calculus cholecystitis in this picture.
What's the upper normal limit for gallbladder wall thickness?
So yeah, from memory, more than I think 7 millimeters is increased.
For wall thickness?
No, I think it's 5. I think it's 5 millimeters is increased. So this is the gallbladder in short axis. or a transverse view of the gallbladder. I think you can see some sludge, dependent sludge, on the right-hand image. And then again, the gallbladder wall appears thickened, and there's, yeah, I think I would just say that.
Anything else that you can see on this, Rob?
I think, I think to the left of screen you can see some edema. So there could be some gallbladder edema, free wall edema, which happens with cholecystitis as well. Right, so this is same patient, is it? Yep. So we're looking at the common bile duct, and we're measuring it, and it's 0.31 centimeters. Now,
the patient's 50. Well, how old was she? 54? 54. 52. Mm.
So I think that's within the normal limit. So from memory, I think you're allowed 4 millimeters up to the age of 40, and then 1 extra millimeter per decade. So that would be within the normal range. Again, this is the gallbladder in more long axis, and you can see the gallstones, which are the dependent gallstones there, consistent with the calculus cholecystitis. This is blood flow, so spectral Doppler, pulse wave Doppler of the what have we got? Portal vein here, which appears continuous in nature, which is normal. So it's non-pulsatile. You will tend to get pulsatility in patients who have got systemic venous congestion, but this is normal flow, so not suggestive of that.
Okay, Rob, so you're waiting for a formal ultrasound, but what would you be, what would your message to the surgeons be at this stage?
So my message to the surgeons would be that I'm concerned that the patient has a calculus cholecystitis and they're presented with septic shock. And so I'd want a surgical review, and I don't think we've got evidence at the moment of a ascending cholangitis, but I am concerned about the cholecystitis that will need surgical intervention to
The surgeons
decompress.
are not convinced and think it's from a chest source. They think she's got pneumonia. So what would you tell them about your findings to try and convince them when you've done the ultrasound yourself?
So I would say that I can see there is increased wall thickness to the gallbladder with evidence of gallstones and pericholecystic fluid. And I'm not convinced of the pneumonia, I guess. I'd need to review the patient. It's difficult to answer that question, but I would tell them that there is evidence. You know, depending on what other information you can give me, Emma, if they've got, if they're Murphy sign positive with the ultrasound probe, etc., then I think that might help us convince them. Yeah.
Very nice. So just recap to me, anyone can jump in. What are the features on ultrasound to suggest acute cholecystitis? If you could list them.
So increased gallbladder wall thickness.
So more than 3 millimeters.
Okay.
Yeah.
Pericholecystic fluid.
Yeah, which this lady had. That's what this was, Rob.
Yeah. And then sonographic Murphy sign, or however you want to call it, is one of them. Yeah. And then I guess supportive features. So having evidence of stones for a suspected calculus cholecystitis, and then evidence of increased bile duct diameter, but it's not required, but can be supportive.
Yeah, nice. And you were right about the decade thing, like, yeah, up to 6 below the age of 60, and then 1 for every decade. But then post cholecystectomy, you can see CVD dilatation, like up to 10 millimeters. Nice. I think those were all the things that we might ask you about different artifacts that you see. So you mentioned about the acoustic shadowing or post-acoustic enhancement as well behind the gallbladder. So yeah, distended gallbladder with thickened wall with pericholestatic fluid. Gallstones here, you want to definitely look in the neck for an impacted large gallstone as well. Dilated CBD, definitely see some gallstones here. And that was just at the end. I should have taken the labels off so it wasn't so easy for you to know what they were, but that was just showing a portal vein. So look, I think in terms of like gallbladder pathology, that'll be the sort of level that's expected, you know, to spot a thickened wall, to definitely be able to spot a dilated CBD, say that you want to look for that. Don't miss the neck stone, like the gallbladder. You know, sometimes that's easy. So just make sure you have a look at a few pictures that show that big gallbladder in the neck, like an obstructed gallstone there. Yeah, know a little bit about the sensitivity, specificities of each of the signs, because obviously none of them are perfect. I think Murphy's positive is probably one of the better ones. So yeah, just remind you that there's like tables in the books and things about the performance of those particular signs.
Thank you.
Cool. All right. And I think this might be the last one. Maybe might be one after this. Hewan or Rishi? Rishi maybe, because Hewan did the toe one.
Yeah, can do that.
Oh, sorry, I haven't given you a stem. So this is a 90-year-old man admitted to the unit after a procedure. I'm not going to tell you what that is. And the handover is that he remains intubated, but he's desperate to have the tube out, but he's had escalating noradrenaline requirements and he's still got a very cool left leg. So you echo him on your ward round, Rishi?
Yeah, so this is a off-axis pastern long-axis view. I'm very concerned about this patient and with this findings. The most obvious finding, which is jumping to my eyes in front of me, is this patient has got evidence of a very narrow LV cavity with evidence of mid-cavity obstruction to maybe extending up to the LVOT tract. Otherwise, looking at the left ventricle appears to be hypertrophic, but that needs to be considered in the context of hypovolemia, where we can get pseudohypertrophy. The myocardial thickness, as you mentioned, appears to be concentrically thickened. LV function is hyperdynamic. There is no regional wall motion abnormalities in the interseptal inferolateral walls I can see, although the image quality is too low to make a good comment on that. I cannot see a good visualization of the mitral valve anteroleaflet, whether it's touching into the to the basal septal wall, because I'm concerned in the clinical context that this patient might be having a systolic anterior motion and LVOT obstruction. The RV, yeah, so we are looking at the color flow across the LVOT. There is flow acceleration and turbulence along the LVOT. So I'll be interested to put an M mode through the mitral valve to look for it and check for gradients by checking through a continuous wave through the LV mid cavity and the LVOT. So look at so these are zoomed apical four-chamber images, which shows which continuing with what we saw in the pastern long axis images, a severely under echo evidence of hypovolemia with kissing ventricles. This patient is hypovolemic and needs to be given urgently fluids. There is accompanied mitral valve leaflets which are heavily calcified. I cannot see the full extent of the late atrium, but they appear to be dilated. The right ventricles appears to be mildly dilated, but the radial function appears to be normal. And looking at the pasternal three-chamber views, there appears to be evidence of flow acceleration right from the apex up to the LVOT, which is grossly concerning for severe hypovolemia in this patient, which is on a high dose of vasopressors. And the continuous wave doctors through the LVOT, which is showing dagger-shaped waveform with peak gradients up to which shows peak velocities up to 2.25 and peak gradients up to 20, which are not terribly high, but the shape itself in the clinical context appears to be highly concerning for mid-cavity obstruction. So looking at the pulse wave Doppler now, which has been adjusted to the zone of maximum flow acceleration, I can see a peak velocities of around 1.5, but continues to have this dagger-shaped waveform, which is concerning. And the claw-shaped waveform, which is very concerning for mid-cavity obstruction.
What can you see at the bottom of the screen coming through there, Rishi?
So bottom of the screen, they could be this could be a aliasing velocities. So this is a pulse wave Doppler. So I think we are underestimating the velocities, the gradient which we are checking. In this context, in the current Nyquist limits, they are coming from the velocities are getting aliased and reflecting at the bottom of the image. So I'll be interested to putting on a continuous wave Doppler through that. So again, this appears to be a some kind of a prosthetic graft in this is I'm not sure exactly where we are looking at. This is some form of cavity or a aorta, or with that in that is some graft.
Yeah,
there.
it's the abdomen around the umbilical
Abdomen.
region. Yeah.
Okay. So we're looking at potentially the central structure, looking at a major vessel. And this probably looks like some artificial graft, vascular graft.
Cool. Bye. Sorry, Rishi.
So my guess is we're looking at a vascular aortic graft, and this is surrounded by massive fluids in the So looking at the long axis view of the aorta, which is a bit more clear, shows clearly about the presence of a graft. There is variable pulsality. I think that's the junction we're looking at of the normal aorta and the graft. And there is areas of flow accelerations, which is happening throughout the graft, which is probably being transmitted from the LV outflow tract and the mid-cavity obstruction. So overall, a very hyperdynamic circulation, grossly underfilled ventricles in a patient who is septic and grossly hypovolemic with rapidly escalating vasopressor supports.
Just look at that again, Rishi, in terms of thinking through the plausibility of that happening, about it being so hyperdynamic, and that's why you're seeing flow acceleration there in that image. Just look at your scale settings and think about that again. Do you think there's going to be high flow through this graph?
Yeah. So you're right. I think the scale settings are quite low, and that could potentially cause a bit of flow turbulence, artificial flow turbulence. It's hard to say. On the 2D picture, if there appears to be some homogenic material inside the graft, so that is highly concerning. Given if this patient is hypovolemic septic, is there any clot forming inside the graft? Which will be my concern, which could also explain the flow acceleration and the turbulence I'm seeing. The short axis of the strength. So we are seeing a two double-barreled graft. And I can see there's a color flow, which is being a 2D picture and a color flow through that. The color flow is not uniform across both channels. On the right channels, there appears to be reduced color flow, which I'll be suspicious of a vascular occlusion or a thrombus forming there.
Cool, nice one, Rishi. I think that's the end. Good job. Let me just play that again. Sorry. How would this change your management? What would your immediate management be for this patient?
So the immediate management will be to manage the ABCs and call the surgeons quite urgently, to the vascular surgeons. This patient will need urgent, correction of the hypovolemic status and systemic anticoagulation if there are no contraindications. You will need further imaging to further delineate the problem, but that I will leave it with I'll do it after discussion with the surgeons and after doing a multidisciplinary discussion regarding what's the best way to move forward from it. The options will be endovascular options, which could be explored, but the acutely what needs to be done urgently is correction of the hypovolemia, addressing the LV mid-cavity LVOT obstruction, and severe dehydration, which will exacerbate the thrombotic tendencies, as well as the systemic hypovolemia and the metabolic consequences thereof, and systemic anticoagulation.
What specifically would you do for the mid-cavity obstruction?
So mid-cavity obstruction, we can think of filling. We can think of measures to control the heart rate, to reduce the heart rate. So we're likewise in this patient controlling the heart rate is crucial for two reasons. First is for the LVOT obstruction, the mid-cavity obstruction, as well as reducing the wall stress on the aorta. This I will be considering for simple measures like pain relief, or doing any other coexisting things which could aggravate this patient's pain or tachycardia. And I'll be very cautious about beta blockers in this patient. And afterload increasing agents can be used in this patient. So switching over from noradrenaline to agents like phenylephrine might be a choice. Agents like clonidine might help. Yeah.
Thanks, Rishi. Good job. So coming back to this case, this is what I was faced with recently in like my last clinical week. So yeah, it was a pretty scary looking abdominal aorta image. But yeah, you're absolutely right. So this is a 90-year-old heart, and he is clearly being flogged with catecholamines. He's got that sort of reperfusion, low afterload state, and he's underfilled, so increasing. He's got sort of structural risk factors, hasn't he, to develop mid-cavity and outflow obstruction with a hypertrophied small LV. He's got a background of hypertension. He's a vascular path. And yeah, those changing loading conditions has meant that he's developed mid-cavity obstruction. So you're absolutely right. We gave him fluid straight away, and actually his NORAD halved after about 500 mils of fluid. And he gradually just got better from that perspective throughout the day, and we were actually able to extubate him. So it wasn't too much of a trouble, but yeah, you got all this right. I mean, he's got a hypertrophied ventricle. You're right though, when they're hyperdynamic and tachycardic, you can overcall that and you can get pseudo hypertrophy, but he's definitely got cavity obstruction the whole way down. He's probably got some caudal SAM as well, although we're not really capturing it. I didn't show you fully the SAM and dynamic outflow tract obstruction, which he didn't actually have. He didn't have any obstruction at the outflow tract itself. It was all really mid-cavity and around that sigmoid septum. Yeah, hyperdynamic RV, and then lots of flow turbulence, just confirming what you're seeing on 2D really, and then the Doppler just confirming what you're seeing on 2D. So you've got that classic like stiletto heel with relatively low, like not super high velocities, but it doesn't really matter. The mid-cavity obstruction is clearly there, and we know that in sort of septic shock cohorts it is associated with worse outcomes when they have this hyperdynamic phenotype, if you like, with mid-cavity obstruction. So doing all the things as you mentioned to try and alleviate that, minimizing beta agonists, giving fluid, keeping his afterload up, all of those things, pain control, you're absolutely right, all the simple things, which is what we ended up doing because he had an ischemic left leg, and he was still in a lot of pain for that, so just switching around his pain relief and things. This does show obviously mid-cavity obstruction as well, with aliasing. What you can see at the bottom here, Rishi, is you can see at the top above the baseline is the mitral inflow. Yeah, so you've got your E and A, so always look at the timing, and then what you're seeing is the tip of the E and the A wave at the bottom.
Oh yeah.
You see that? So you've got the wraparound. So just again, they could just show you this one image and say, tell me what's happening, explain the physics. And you've got to, so it's all about timing, right? So don't always look, whenever you're asked about Doppler, always think, is it in systole or is it in diastole? And then you can figure out, like, am I using pulse or continuous? And is the flow actually in systole or diastole? And then you can sort of figure it out logically. Because if you looked above the baseline, you'd be able to figure out that that's just the aliasing of the E and the A because of that range ambiguity. Yeah, this is scary. I mean, you need some clinical context for this, right? So this man had a ruptured AAA in the past and had an EVAR, and he had an endo leak, which they tried to fix in the past, and he was no longer having like an endo leak, but the sac had increased in size. And it's below, it's where the bite, so you're seeing two lumens because it's where the EVAR graft is bifurcated into left and right iliacs, and he completely
the trouser
occluded the
gaps, which is
left.
there.
The trouser leg, yeah. He'd completely occluded the night before. He completely occluded the left side. So he had an ischemic left leg and developed compartment syndrome of that left leg. So this is actually after the embolectomy and the stents and things. So they've actually fixed the problem, but there probably is still a little bit of thrombus in that left-sided. I didn't tell you which one that is, but that's the left-sided graft there. Just be careful about making that assumption that you're getting turbulent flow all the way down to your left iliac because of outflow obstruction. I think he's probably got a low outflow state, right? Because he's obstructing and things, and he is in, he's got the velocities are down at 13, so you can't really make any sense of what the flow status is, except to say that there's there is flow in the graft. I don't think we can, with velocities that low, you need to have some spectral Doppler and some clinical context as well. So always make sure you look at the scale, and try to it needs to sort of make sense physiologically. And then you can probably see a bit of thrombus in this one. Can you see that? That mobile
it's wiggling there.
Yeah. So we did contact, and then you can see that there is essentially this flow in the trouser leg part of the graft. But yeah, highly concerning, and you need to look at previous images. And the vascular surgeons came. We actually didn't do anything about it. He couldn't actually have a heparin infusion because he was bleeding from where he had the compartment syndrome and the fasciotomy site. So we had to just sort of manage it initially conservatively, and then later he was able to be started on more aggressive anticoagulation. But yeah, it was really quite tricky.